Okay, go ahead. I was just going to say, Maggie, you're a guest, so you should go first, and then Susan should go after you.
Okay.
Susan will go last, not a worry. Susan, can you take a break?
Nurse. So I've been a nurse for 23 years, ICU, ER, pre-op, PACU, endo, IR, cath lab, taught ACLS, BLS. When I had been a nurse for about 15 years, went to the board of nursing as an investigator. I was very policy driven, had left the emergency room. And so this is the stuff that we're not going to keep. Some of it I don't want in. I do talk about my concerns about the board of nursing, but when I was there for a short period of time, like I didn't become that intimate until I was there and I wasn't given a choice. I went to national training and then I became very intimate with it. So I am, a little, like yourself, a unicorn in my little world because I have bedside experience. I was a civil expert, administrative expert. I came within that entity. I don't know any other investigator.
Yeah, so I thought that Maggie would be invaluable to kickstart this summit because one thing she knows back and forth, and if she doesn't know it, she knows where to find it and can kind of intuit from knowing the Nurse Practice Act so well, is what do nurses need to know to protect themselves? Like if your hospital is not preparing you to run a code blue or do the very basic, call for help, start CPR, use electricity, like if they don't know that they're obligated to be able to do that, like, and if your management or your administration isn't training you, well, it's kind of on you. I mean, but you can speak more to that, Maggie. So, Susan,
tell Maggie.
Susan, why don't you tell Maggie while we're all here?
Yeah, I mean, you can just start this whole thing. Let's go.
Well, no, I'm just listening with such intrigue. And Maggie, I've very much been looking forward to our conversation today because like you, I'm sick and tired of being sick and tired of what we're sick and tired of. And the list is long, but you have your niche, right? The list is very long. I mean, we've discussed that in many of these podcasts. But I have my niche, you have yours, and mine happens to be cardiac arrest response. Very specifically, in-hospital cardiac arrest response is my specialty. My background in nursing was trauma, emergency, some cardiovascular care that I've done. I have my paramedic license. I've done some flight. I've been the director of the American Heart Association for a large healthcare system for the last 10 years. I'm now the resuscitation education manager for a big healthcare system. All that is a whole lot to say about me, what I'm sick and tired of. And that is the fact that we've been talking for the past 1800 years about the fact that our codes suck still today, as they did back in the 1800s. And I don't think it's really rocket science to fix it. In fact, I think it's far less than that. I think it's super duper easy. And no matter how I word it, no matter how I say it, no matter how I build it, this is, pushing the rock uphill to have the opportunity for nurses to get the training that they're asking for. And this means going beyond the minimal standard of, our once every 2 years. You said you're an instructor. I'm also BLS, ACLS, PALS instructor, have been for years. We all know that that's not enough. We know it. We're not seeing what we need to see as our outcomes clinically, period. We're not seeing, I listen, and I'm not going to dog anybody who is getting the great outcome. So hallelujah, amen, and join our conversation. Join us because like you said, it's not all, bad. We're not generalizing, but in general, is the code blue practice is the #1 most requested educational intervention by nurses around the world. They might get a random mock code bomb where they feel stupid and put upon and like, if you don't fail me now, well, of course they're going to fail me now if you put me on the spot like that. And if you don't happen to be on that unit at that day, at that point in time, then you don't get the benefit of that practice. And many hospitals around the country and the world have come up with their idea of how to make this better. In my findings, it's not standardized, it's not consistent, it's not enough. And so that's what we're here for. I created a program a handful of years ago now, nearly a decade. I've been doing what I call code prep, and it is a code preparation program. It's pretty simple. I mean, we talk about mindset first, and that's kind of, Maggie, the outline of this conversation, and the same outline we've used with every one of our guests. Sometimes we get to all the points, sometimes we get stuck on 1 or 2 of them, and that's okay. And I cannot really wait to dig into this with you, because I've broken into, in my doctoral work, I've talked about accreditation standards and, the minimum, what do they have to have in order to function as a hospital in not only our country, but around the world? And are we meeting that just by the skin of our teeth? So we're here to talk to different nurses through different lenses. We've spoken with OB nurses, OR, an OR nurse, a United States Air Force flight nurse, a rapid response nurse, a travel nurse. Oh, that was our travel
neuro med surge.
Neuro med surge. Oh, yeah. So, we often talk about the hospital in our cool show here as being a hamburger. So ICU being the top bun, ER being the bottom bun, and everything, the hamburger in the middle. And what does it look like? What does it look like through your lens? What does it look through mine? So you, as a clinician, you've responded to codes throughout your career, I'm certain. You also will have an opinion on the mindset, which is the first topic of where we begin, the mindset. How do you feel about Code Blue? And it could be personal, your personal training, how you felt when you were a new nurse, how you felt when you left the bedside that it was going. How did you feel about your training? Was it adequate? And then the other pieces really kind of just fall into place. I mean, the whole premise is, can we, as the however many millions of nurses we are right now, actually very confidently recognize the problem, call for help, begin compressions, and use our electricity without fail, like ordering pizza, like not a big deal. And the answer is,
No, we can't.
No, we can't.
Nope.
And then do we practice all the time?
Nope.
No,
That's
we
why
don't.
we're here.
And that's why we're here. So that's the summary. Code prep is something that I have been doing locally for nearly a decade, and I've trained hundreds and hundreds and hundreds of nurses. I've trained coaches. They love it. It's a little tricky getting leadership, to allocate resources for something that's
Needed.
I don't
Needed
know.
for nurses. Needed for nurses. Heaven forbid we do that.
Heaven
You know what?
forbid.
To that point, the common theme between what the two of you do, which I love, is Susan's thesis that she did, and correct me if I'm saying that wrong. It wasn't about training. It was about how can we get nurses to feel like they're confident, that they're capable, so they don't go home feeling like there's something I should have done or could have done. Just, I've got this. I've got this feeling. I mean, I don't want to go through it really. I'm kind of scared shitless to go through it, but I know what to do. Same with what you're doing with Knowing Your Nurse Practice Act. Like, nobody wants to get in trouble. Nobody wants to go to deposition. But if you know your legal rights, the standard of care that you're supposed to deliver, if you know your Nurse Practice Act, at least you can have the confidence and not be like bewildered, like, what do I do? I don't even know if I did something wrong. Well, if you know your Nurse Practice Act, then you do know, what you're entitled to do, what you're responsible for doing, entitled to get, responsible to do, all that stuff. And at least you have that confidence and not the bewilderment and the vulnerability and all that. And that is something very similar, different expressions of the same desire for nurses.
Yeah, absolutely. I mean, I'm in my mind when you were speaking, Karen, and waiting to hear from you, Maggie, is this term called failure to rescue. There's got to be legality behind training that's been provided. They've been signed off on their competency, that they have skills, code skills. We'll talk about, my particular topic. We have a BLS card. Now we're in a room and we don't get compressions in 1 minute. We don't shock within 2. We scramble and, like I always say, the bird's on the bottom of the cage. We wait for rapid response to show up 3, 5, 7, 9, 12 minutes later. They're on their second code. Okay, now they're here. There must be responsibility on someone's back when that goes wrong.
There is.
Whose is it, Maggie? Do tell.
So I can tell you that the last case that I testified in not this last February, but the February before last, a code was involved. And so what was on the big screen? In a civil case, there wasn't a jury involved. It was the code sheet. And what was not done? It was so done poorly. No check boxes. You and I, everyone here knows they were bagging a patient. We can see it. We can see the code, but they can't. And so do you think it was checked that they were bagging the patient? So the expert in their report, I can't say you were bagging the patient. I can't make that up. That's me lying. Now I can say when I'm testifying on my report that I can say to that, yes, I can, standard of care would have been, or in my experience. But if it's not charted, you didn't do it. And it was simple stuff like that. They didn't check a blood sugar. This was a diabetic patient in MRI. What should you be thinking? Sedation. No one no one talks about Razakon. They sure billed the patient for Razakon, which again is another slap in the face. The patient got billed for a drug that they never even got. And that again is on the big screen. The code sheet was there, the poor documentation now is reflective of maybe you. The jury doesn't get to see maybe you, and now they see this Mickey Mouse, and the other side has already painted you as poor providers.
Yeah, this is the first time we've started with charting, but
yeah, but it's good.
I love it.
We need to go down.
Dive right in.
Wait, wasn't there a paper towel up there on the screen with all the notes, all the documentation? Like, come on.
Well, that's the thing that was missing.
When I was teaching ACLS, I would tell people, and of course they think that I'm sometimes ridiculous, but I'm like, do not take, when you're the documenter, that's not a job you should be taking lightly. Like, don't let that's your job. That's why we each have a different job. Take it very seriously. And yes, you're gonna have to ask you, what's your name? I don't know your name. There may be people responding to a code that you don't know their name. Or when things have calmed down, then you still have to go to them as the documenter and say, hey, I'm sorry, what was your name again? I know you were here. Because other people are doing other tasks. That's your job. Take it seriously. That is a big deal, because if nothing else happens, but if it does, and now it's on the big screen.
So Maggie, I think what you're saying is really important in this conversation, because what I'm hearing you say is, if you're in a code and you're the documenter, as the example, you better know what you're doing. And if you're not getting it from your hospital, you're still on the line. And so I'm hearing in the background, know your scope of practice, know what you're supposed to know. Now, it should fall on the organization, but as we know in code, it oftentimes doesn't, right? So I think to your point, like up on a screen in a trial is, whoops, you didn't know how to document. Who is that on, right? So I like how you frame that, because I think in this conversation, I'm curious to see what Susan says about that.
Well, I think we could talk the next 6 hours on code documentation or nursing documentation at all. Code documentation, however, is and has been, again, since the beginning of time, such a nightmare. I'm working on a case right now where the code sheet doesn't match the defibrillator, which doesn't match the physician's notes. None of them, like the drugs are different, the dosages are different, the timing of everything there's nothing on there. And then each of the other sheets say refer to the physician's sheet, which I feel like he wrote after the fact. So you want to talk about a hot mess, but we digress, because fixing code charting, I'm not going to say I'm not taking it on, but when I was requested and created code prep, it was, Susan, could you just get them to do compressions before we walk in the door? And I was like, yeah, this is so silly. You're right. How come we can't? Where did our training go wrong, Maggie? Where did our training go wrong that we are not sure if we should we? We hesitate because of the hierarchy, because of our relationships in the hospital, because of, are we scared because we're not sure, because we're sure that someone else around here probably has done it more than we have and knows better than we do. So we wouldn't dare get in the way, and we wouldn't dare do it wrong. So let's bring it back around to mindset, which is the opening module in code prep. The modules are mindset. So we'll circle around back to that. The second one is visual acuity, which is a triage system that I created because we like to say the best cardiac arrest is the one we prevented. So what are we doing to prevent it? How to catch the signs and symptoms of deterioration before the, tank moment. Our emergency equipment. Do you love it? Do you hate it? Are you afraid of it? There's a huge amount of fear around that darn defibrillator. You hear that charging sound and everyone falls out. They just fall out. And then rescue 1, 2, and 3. What are the job of 1, 2, and 3? Who is rescuer 1, 2, and 3? people have hospital systems have code roles, right? And everyone, I'm the runner, I'm rescuer one, I'm the compressor. What happens when they're out to lunch or off the floor? So in code prep, rescuer 1, 2, and 3 is everybody. So back to mindset. What do you think about when you think of code blue training for yourself as a nurse? And any example you want to give or how you feel about that?
I definitely feel like I've evolved. As a new ICU nurse, I was scared. But no, don't code operation. And then ACLS was just so intimidating. It's like you went into this room by yourself with these scary people who asked you questions that you were never gonna have the answers to. It was very intimidating, I feel like, early on. I feel like it's gotten way better, maybe a little bit too lax. And I do feel like as I've gotten more experience and as I have moved around into different settings, like the ER, because I have seen code after code, but I feel like I've gotten more comfortable. A code in the ER is different than a code in the ICU, and a code in the cath lab or the PACU. So I've seen different codes in different settings. So I feel like I have a better comfort level for sure. Being in the cath lab, that put me on a different, I feel like, comfort level. I don't know why, just because I feel like a bunch of just competent people and a small, everyone kind of knew their place, and as a team just worked more cohesively. I felt like we already have pads on a patient. We already have things in place that also help aid that. So I already have it up to 300. Anyone who comes into the cath lab, they're getting DFAT pads on. That's just part of our protocol. So it's just a little bit more controlled of a setting. And I was more comfortable with those drugs. So I do feel like my practice has evolved. I do think that people are generally scared. I mean, I remember the first time I was a newer nurse, I was pregnant, getting up on the bed and doing, compressions for what seemed like way too long before someone came to relieve me. Because again, in a small ICU, I didn't think that people were comfortable. I don't think that people are generally comfortable responding to a code. Even physicians. I mean, I've walked in, I've done interventional radiology, went to go check on one of my friends, just one of the other coworkers. She just happened to be my really good friend. The door opens because they're lead walls, and I hear her screaming at him, and he's just standing there. She's coding the patient, and I'm like, go get the crash cart. And I immediately move over to her to start helping her, but I'm directing him, an interventional radiologist. I just feel like that they're not. And as teaching, I taught at Baylor, so I taught the students, the med students, everyone comes, respiratory therapy, other nurses, all the disciplines come, and you would see them on a code, and it would be scary. The biggest thing that I think the defib is what people are the most scared of. Pacing someone, you ask them, they can't. Or to offload a charge, right now, you ask 10 nurses how to do that, I guarantee you. And that's something that I learned in EP. Because again, we'll load a charge if they're gonna pace someone, and we need to pace them out of that rhythm. So now they were able to take them out of it. Now dump the charge. And I've seen them deploy it into the patient, and the EP doctor lose their mind, and rightfully so, right? In that setting as well, I've seen 2 defibs hooked up to a patient, and then you're supposed to synchronize. So other point being is that I feel like nurses as well need to leave one setting. I think that the more that you move around, and that's of course me, as a critical care nurse, the more that you move around and that you're comfortable and that you touch things, because my comfort level did come from doing it repetitively, being more comfortable with my skills and the drugs, for sure.
Maggie, how often did you get to practice in, or how often? Yeah, what was the practice like? I mean, you did it over and over again in those critical care areas, but did you see that people were getting adequate training?
No, it's every 2 years like everyone else. Actually, they implementing something new at Baylor where I think it was like every quarter, yes. You would go, there was a machine hooked up somewhere on the second floor to a couple of dummies. You had to make sure you did your test first, and then you checked your box off by doing that. So I believe that's what we're doing.
Yeah, Maggie, you're referring to the RQI. That's the American Heart Association, yes. And Laerdal. They have the RQI program, which stands for Resuscitation Quality Improvement. And this is something that similar to the conversation we had right before we push record on this call, would be an area that I could weigh in quite heavily on the efficacy of that program. From the giants in our world, from the giants of the resuscitation science, the best. That is their recommendation. So that is the recommendation. They're going to take the course at home online in your jammies, and then you're going to come to a self-directed mannequin connected to a computer where the avatar will be your rescuer number 2, where you practice compressions that are very difficult compressions, but I like it. Good feedback, and airway, which we all know how good everybody is at airway if you're not a respiratory therapist. But I would, based on what you were talking about, your experience is amazing. You are a critical care rock star prior to your legal stuff and or during your legal learning. But I would like to pinpoint something that you said that stood out for me, and that is, no matter what your experience is, and here you are giving all these advanced techniques, however, you're still not that, you, them, in that area, all that in a bag of chips, right? It doesn't matter how much experience you have or how good you are, physician, dual defibrillating, dumping charges, those are advanced skills, but if you don't practice it, and you have, okay, let's say you're the one, and the same goes back to recording. There's usually the same person takes that same job regardless of your area of expertise. There'll be like 2 crackheads, I call them, in the ER. They run to every code, or in the ICU, and then everyone's like, listen, I'll watch all of your patients all day long. I'm good. In the cath lab, you guys are in there causing cardiac arrest. So it's just like, it's like, again, did you guys? I said no pepperoni. Yeah. Oh, code. Blah blah blah. But still, if you don't practice it, and that's the whole big deal that we're talking about here. And in the same case that I'm referring to, you guys, with the one that had all the different documentation, none of them matched. One of the questions was, so do you guys practice mock codes? And they said, well, yeah, we have to do a mega code every 2 years in our class. And I was like, oh, brother. Did you just say that?
Hey, Maggie, from a legal standpoint, do you know kind of like what, I have not memorized my nursing scope of practice. Every time I see you, I'm like, oh, better get back on that document. but like from a legal perspective, what does that look like? What is my responsibility as a nurse in a code?
Sure. So when you say legally, so there's civil, criminal, administrative. So a nurse is 98% more likely to stand in front of the board of nursing than she is civil criminal. Okay. Even though we're hearing all these cases in the law and in the media. But when a patient codes, you're more likely, and if they die, you're more likely to stand in front of any of these courts, right? You understand that statistically speaking, if there's a bad outcome and a patient loses a leg, a patient dies, there's a code, that's probably going to be under microscope. So what is your responsibility? You're showing up as what? The primary nurse, or you're part of the code team?
Either.
Okay. So you're the primary nurse. So let's just talk about this nurse. This is a civil case that's already resolved. So I can speak about this. The primary nurse was the one who gave an AMPA D50 to the patient, and then 2 milligrams of Ativan, took him off the monitor down to the MRI scanner, where within the next 7 to 10 minutes, a code blue was being called. People were running down to the code, to the MRI scanner, where the MRI techs recognized that he was not responsive, but failed to initiate CPR. And because I'm an ACL instructor, BLS instructor, I was able to opine in this case, not on their scope of practice, but of their failure to respond to an unresponsive patient, which they don't. They literally, and under oath, they both say they never do anything. They pull them off, they pull them out, they get them onto the stretcher, move them out into the little ante room, and they literally wait for the code team. Neither one of them initiate basic life support. That's not defendable. The hospital had to write a check because that's not defendable conduct. So now they're negligent, and now you're just showing a whole system negligent, and that's what the attorney wants. So now check the, not only did the nurse not do what she was supposed to do, now we have the MRI techs who also failed to respond. So what was the responsibility of the primary nurse? A, to get an order to take the patient off the monitor to go down to MRI, not to send an unstable patient off the floor with a blood sugar you're chasing. unless it's a stat MRI, why are you sending this man anywhere? Why are you doing that? And then to give a benzodiazepine to a patient to go off the floor. So she had a lot of responsibility.
So failure to respond is important to know. How many nurses do you think know that?
Not many, not a lot realize that can end you up. And now at the board of nursing, if it's a civil case, you have more of a chance. If it's the board of nursing, and you all know that's why I'm here. Good luck. Let me know how that works out. So I'll be here. I mean, I don't know what to tell you. You can't defend that. And now the code is, people are running to the code. If I'm part of that code team, I look down, he's brown. His last name, again, I'm thinking diabetic. He's how old? They got him up on a wedge. He can't even lay flat. So all these things are going through my mind as a critical care nurse. Because they do have to put him straight up again. He's unresponsive. He's down an MRI. What do we give down an MRI? Benzodiazepines. So and none of that happens. The code sheet's not filled out poorly. They're not bagging him. It doesn't show that they're providing any supplemental, oxygenation. There's no monitor on him. When they do get a monitor on him, shocker, he's in PEA. And so he died.
So you have all this perspective because of your background and experience. The hamburger, the people in the middle aren't going to. And is that even part of their nurse practice to act, to think, I've been places where, the SATs are in the 70s and the patient's not even on oxygen because the nurse is waiting for someone to tell them to put the patient on oxygen. But you do that on your own in ICU and ER. You see a SAT or you see a color and you just automatically, because that's how you respond to that. But if you're not used to it, you don't.
Then under BLS, you're allowed to do that.
So I guess this is my question. Is the nurse who is not trained, I guess, number one, you need to get trained if you're not. But what are they legally obligated to do? Failure to respond. If the patient is unresponsive and you do nothing, that's kind of I guess that wouldn't be even written into the Practice Act, because that's kind of common sense. Go ahead, Susan.
Yeah. So the question prevails. You said, Maggie, they have BLS. Well, that's the answer. Is that the legal answer? Is that the safety net that a hospital has that says, we made sure she had a provider card that was current, and there's her training. So if American Heart Association says that once every 2 years, although they do say, and they have since the 80s, they recommend it every 2 years, but there is a statement every year, every 5 years when they do their updates that says that 2 years is too long. And there's research out there that says, they lose the knowledge from the class as early as 3 weeks, 1 month, 3 months, 6 months. It's proven since the beginning of time. But legally, if the training that's been provided, that nurse has a BLS card and then doesn't do the basic, which is why I'm such a craziness about BLS, because we skip it all the time. She didn't recognize the problem, or then maybe they did. Did they call for help? Maybe so. They did not initiate compressions and use their electricity. So is the safety net the hospital can say they have their BLS? That's the requirement. So now
it wouldn't just be the basic BLS, because there's education, there's an order to start, initiate oxygen if SATs are less than 92%. There'll be evidence-based science that will be pulled in. And just like you said, either expert can use that data, like you said, either way they want to in their report. So that door could swing either way. Now, it was risk management that was defending the code sheet. And again, I don't doubt that they did everything that they could. But when there's an expert call, you can't ask them to lie for you. You can't ask them to say, yes, they were doing it when that's not what the documentation says. The documentation does not say that you are bagging the patient, but we all know, because again, that expert also will be cross-examined and will be saying, so you're saying that they weren't bagging the patient. Have you seen that? And the nurse would have to say, no, of course I have.
So that brings me back to the second topic then of early warning. So in the code prep system, because I know, and I researched all over whatever, blah, blah, that many systems use early warning systems. They're computerized, they're in the EMR, EHR, whatever you want to say. My conclusion is they're only as good as the information that's fastidiously inputted into them. Yeah, they're getting more advanced, and they draw from labs, they draw from vitals if they happen to be, you can pull them in and so forth. But in all actuality, and again, that lies right on the nurse's back, just the nurse, not all the other people that are on the floor, right, that are looking at patients every day, just the nurse. So in code prep, I used my pre-hospital brain and put together a visual acuity scale, green, yellow, red, sick or not sick. Really, really, really drawing in on that word acuity. I think our country's gone crazy. I think nurses have gotten crazy with the word acuity. Acuity means sick or not sick. I am not comfortable with people using the word acuity for staffing and for room assignments based on the number of tasks that a nurse may or may not have in the hamburger of the hospital, right? Lots of tasking equals a higher acuity. Why are we teaching that? We already know that their brain in the hamburger doesn't work the same as critical care brains. Critical care buns are always thinking sick or not sick. That means vitals are Q5. That means to Karen's, we automatically, the breathing looks bad, oxygen, like we do it. But in the hamburger, if we're talking about acuity as the number of tasks, I feel that their brain is at kind of an off mode for that sick or not sick. So legality, here we go. We missed the signs and symptoms of deterioration. We know patients show signs 24, 8, 3 hours prior, absolutely. So we miss it. Now we're having an arrest. So going upstream to the legality of missing the signs and symptoms of deterioration, and we know there's a million reasons why. But once again, is the training from our basic advanced and pediatric life support enough for us to catch the early signs of deterioration prior to arrest?
I don't think so. Not with staffing. I mean, the patients are sicker and sicker and sicker. The responsibilities of these nurses is outrageous. Coming to me, I mean, a nurse was just like, I got written up by management because I didn't have my CHG wipe done in, it was on, 12 hours and 15 minutes. Well, I mean, how could you, how dare you? I mean, some of these tasks are just so ridiculous. You're so weighed down. And so when the nurses, legally, if a nurse unfortunately takes on an unsafe assignment, that could put you in a bad situation. And I know staffing is, I'm with you. It should not be based on some crazy number. When people talk about acuity, do we really know what that means? And when people making assignments are basing staffing off of that, based on what? And they're using a term that they think that they know how to use. And so nurses are being tasked more and more and more. And so when someone fails to respond or fails to, use the chain of command, those are all real things for a nurse. It's obviously the 1%ers that come to me. I've seen more administrative than I have civilly. Administratively is more I'm concerned about because that can affect a nurse's livelihood, which is their ability to work. So if a nurse, failed to respond, you pray when you stand in front of the board of nursing that you have someone like myself who will help you put the map on the big screen to say, hey, I had 12 patients and I would have had 6. And then just pray that the board of nursing will see what that means. But physicians are roped into that as well, for sure.
Andre?
I think that's just a really good point that if you're going to get called to administrative action for failure to respond or for failure to, use your warning system, then you better be darn sure as a nurse that you know what to do. Because if you don't,
yeah, if you don't see them though, because you saw them twice in an 8-hour shift because you have 12 patients, that's, you can't even implement, green, yellow, red, because you're not looking at them. Susan, well, just to add on, we've talked about this like 3 out of 5 of the chats we've done, but I really think that acuity thing, I keep hearing fragility, like instead of acuity, fragility, and you can have, I don't know if the acuity level belongs under the fragility level or fragility, like you could have all these tasks and then it's level of fragility. And if it's a yellow or a red, well, then that nurse has to have less patience. It's not about the tasks. It's about how often they have to go look if they're sick or not sick. But who are we to change?
Yeah. Would you quit all that common sense junk, Karen?
I know,
Please?
common sense.
Wow. Well, and to your point, right? This is exactly why the visual acuity scale in co-prep is for everybody, clinical and non-clinical. It's you can tell by looking at somebody if they look like they're sick or not. And so we use RPMs, respiration perfusion, and mental status. And it's honestly thumbs up or thumbs down. This is an across the room assessment, 10 seconds or less. Housekeeping, nutritional services, PT, OT, case management. Everybody has this 10-minute module on the fluctuation and possible, red to a green and a green to a red, yellow in seconds. But how can the nurse possibly be responsible by herself? So the visual acuity in co-prep is for the wingman, wingwoman, wing team. It takes a community to save a life. The European Resuscitation Union stands by there. It takes a system to save a life. Systems saving lives. Yes, bravo, European Resuscitation Union. I'm with them on that. So that's the whole 9 yards on not leaving the nurse by herself in her 12, 6, 8, 10 patients. Acuity because we have 85 tasks in one room and we can't even get to the next room. God forbid one of them codes in room 1. Well, who's going to do my other 12? So anyway, Nightmare on Elm Street there, but we know that. So that moves into the next one, and you touched on this, Maggie, is that fear of the equipment and the handling of the equipment. And in co-prep, we teach literally the 1, 2, 3, step 1, step 2, step 3. You don't have to be a rhythms expert. You don't even have to know the rhythms because the machine does. So there's a little button on that machine called the analyze function. And in co-prep, everybody learns the analyze function by pushing the analyze function. Step 2, 1, turn it on. Step 2, analyze or charge. In my world, everybody pushes analyze. And then step 3, if it's a shockable rhythm, when it glows red, glows orange, red, whatever the color is, you clear and push the button. I can't tell you how often I have to yell, push the button. So I'll get my buns. They're like, we're gonna use the analyze function. Oh my God. I'm like, yeah, listen, you've got 4 minutes. Just show me you got this. And then, and then we'll go right on because of those who, you guys, then you're all that bag of chips. I know you are. So that's cool. Show me, and then we'll do things like pre-charge or defib and remove that charge if we're not going to need it. We can do bonus round of compressions while we're charging, but you can't dare bring that stuff in early because I'll tell you what, there will be no bonus rounding. The pads will be on like this, and it's like, oh my goodness. So I can't tell you how many times ICU teams, just yesterday, ICU team, push the button, push the button, push the button. The glowing orange one, push the button. They're like, my ICU team, they're like, well, we need to get into the drugs. I'm like,
But this level of joules doesn't work with that kind of bundle branch block, and it's a 3rd degree block, and you don't use atropine in that case.
Exactly. Meanwhile, and I even teach Maggie, you got the random physician in the room, like the case you were describing, and everyone, the nurse is running the show, and I'm like, oops, whoops, we pushed the button, oops, no harm, no foul, Oh, it's a shockable rhythm. Everybody clear. We got this. Push the button. Back on compressions. Ordering pizza again. So it shouldn't be, so handling the emergency equipment. You worked in areas where they handle it all the time, but I worked in emergency and trauma and cardiac stuff. I never knew the analyze function existed. So that's a big thing on your emergency equipment. What's your take on that? You feel like, we know the answer, don't we, Maggie? But how often do people get to use their cart?
Yeah, no, I don't know that. I only know this because I taught ACLS, but I didn't know that before I was an instructor. I didn't know that really was a thing. And then it's like a little bit of an ego thing, which I talk about, which we got to put down. That has to stop. That I'm so tired of that. That needs to end. So part of it is I can interpret it. Okay, whatever. It's just not appropriate. So I see that depending on where you're at and the hierarchy, whether they'll use those tools. I definitely feel way more comfortable doing cath lab in EP with rhythms, with conduction, also with perfusion, because cath lab is plumbing, right? There's blockages. So I feel comfortable with that. And then conduction or the electrician. So I work with plumbers and electricians. So I feel comfortable with those two. So I feel more comfortable with the equipment, and we would have to charge all the time, or you're putting in a ICD, a defibrillator, you do have to load up a charge. And it was like one of those first times, like when I saw a nurse do it, deploy a charge, and she wasn't supposed to. Oh, you can be real for sure. I introduced myself to how you offload that. So I would never do that again, because again, you don't know until you're there. And you're there, because again, that sound is crazy. And everyone's like, you know, turn it off. And you're like, and the first thing that she did was touch the charge button, and there it was, and everyone cringed. So
Well, for people who can't picture, has never been in that situation, what happened when she didn't offload the charge and that ICD was connected to the patient's heart?
Well, so the physician was able to pace him out internally with the EP equipment out of the lethal rhythm, so the patient did not have to be shocked. So we loaded up in case the internal equipment doesn't work. So the internal equipment or the patient doesn't come out of that rhythm. So then the nurse needed to offload that charge and didn't, and deployed it into the patient. Thankfully, the patient did not have a bad outcome. If he would have, thankfully, he was with the electrophysiologist in a place where they were, I mean, we could have paced them out of just about anything, thankfully, but imagine it wasn't that setting.
Yeah,
that could have been bad.
You know, that makes me think of, again, in the hamburger, I always wonder, as I started studying this, I always wonder, where was the ingenuity of placing equipment, defibrillators, manual defibrillators, on every floor, 2 or 3 of them, some floors, some hospitals, in the basic life support hamburger of our hospital, but we have advanced equipment. Now, I know some hospitals have AED defibrillators in those areas. Many do not. Some have one. Random floor has an AED defibrillator, all the rest are. So in the middle of the hamburger, everybody's BLS trained. There might be one ACLS person in the unit, a charge or a supervisor. So then I'm just wondering at the ingenious idea that someone had to put all these advanced cardiac life support pieces of equipment in our basic life support areas. And then we wonder why it's not used and why there's fear. Is that really far-fetched, guys?
Well, what would your suggestion, just to have maybe still, I mean, if you want the capability of running a full code on the floor, or are you suggesting just have BLS and then wheel them up to the ICU doing BLS until you get to a crash cart?
I'm suggesting make a big stink out of the analyze button. If you're gonna put the advanced equipment everywhere, make sure that everyone has been exposed to and has the training to use it, and to turn it into a piece of BLS equipment, which means they are not waiting for the superheroes to arrive. They're not waiting for the physician to shock. They're not waiting. If you can, again, my platform here, if you can shock in the mall or in the airport, you can be a 10-year-old kid, you darn sure should be able to do it in the hospital by trained healthcare personnel. So I'm saying, put the equipment there, but make sure they have the training to use it.
Yeah, Maggie, this is for you. You just reminded me, Susan. So we've talked about this on a couple of these calls, that the nurses in the middle of the bun will, like what you were saying about the guy down in MRI. You know something's wrong. You've called for help, but you don't start compressions because you're waiting for the doctor to tell you it's okay. You don't hook up the thing, or maybe you hook it up, but you don't push the button because you're waiting for the doctor or the code team to come. What is the nurse's is there one? Is there a legal obligation for them to, because they're BLS trained? I think we're covering this in yet another angle. The nurse who's waiting for the doctor, are they going against their Practice Act instead of just initiating CPR and using the electricity before the doctor gets there? Like, I want every nurse to be really clear that you have Susan's permission. You have the permission to not wait for the doctor. That's a cultural thing. But you are trained, start compressions, use your electricity, then start compressions again until they get there. Am I correct? Like, that's their legal practice obligation, correct?
Duty. Keep saying the word duty.
Duty.
Duty, duty, duty. When you have a professional license, the word is duty, and they will smack you down with that duty. Yes, you do have a duty, and you are bound to, because you learned BLS. And under testimony, both the MRI techs, one had to say that she had taken BLS 22 times. The other one had to say that she took it like 11 times. And
I think that's really important for nurses to hear. It is their duty. They don't have to wait for a doctor. I mean, we're so stuck in this hierarchy of the doctor gives the orders. You're going to get in trouble if you don't wait for the doctor. It's just maddening. And that it is their duty as a nurse to initiate CPR, especially I think if they've had BLS. I mean, I don't know what it is if they have. What nurse isn't BLS trained, right?
I think you have to have it to be a nurse in a hospital.
So
Susan.
Yes, everybody in healthcare. If you're in healthcare in any manner, you have to have basic life support in any form of healthcare. And you can't even be a student in anything in healthcare. A student of the health professions, dental, radiology, all of them, respiratory, CNA, everybody has to have basic life support. So
Yeah, and Anja said you don't have to wait for the doctor. But according to you and Maggie, it's like you must not wait for the doctor.
So yeah, so when I go back in the day, I call it up until very recently, in fact, I call it, I've been code prepping in dark alleys because I kind of had permission to be there, but not so much. And they were like, how are you doing that? I was like, well, they call me and they ask me for it. And then I go there and we do it. And they're like, so how did you? I'm like, listen, I'm sick of waiting. They asked me for it. Like they literally passionate managers, supervisors, even staff. So I'm like, can you please come in and train my teams? I'm like, yep, I'm on my way. So to cover my backside, I would always call risk management. And I would say, hello, risk management. This is Susan, the rescue RN. I'm coming in to train some of your team members. I will be teaching to use the analyze function. What's your take on that, kids? And they say, oh, well, is it the standard of care? I said, yes, it is. So it's the standard of care, pushing the analyze button. I said, yes, it's in every BLS video. It sure is. They said, well, as long as it's the standard of care, and the people you're training have been exposed to the training and have been signed off. So a competency has been done, which is a BLS card, yes or no, right? If they have a provider card that from the American Heart Association or Red Cross or wherever that is current, then there you go. So I'm like, okay. And then I would say again when I got to the floor, I said, now I've checked with risk management. I want you to check on your side, as long as your director approves and you check with risk management, because we will be pushing the analyze function, which means we will be shocking before anybody else gets there. Because when we practice, we do it in a minute and a half or less, again and again and again and again. So there's your duty.
I
Duty
concur.
versus duty.
Yeah, and usually those
I
machines,
concur.
do the machines, I guess they don't do like what the AED machines do on the crash carts. Well, not all of them, but there's even a little guy that comes out that says, continue compressions, analyze.
It does.
Analyze.
It does. Karen, when you push the analyze function, it turns it into an AED. It'll say, begin compressions.
Yeah.
Faster, deeper. It'll give you feedback. Then it depends on what type of defibrillator you're using, what type of feedback, what type of pads you're using, what type of feedback you get. But it will, and then it'll say, analyzing patient, clear the patient. And then it'll be charging, whoop, and then that's the part when everyone falls out. Shock advise, shock, continue compressions. It will talk
There
you
you
through
go.
it. And then 2 minutes later, it'll do it again. So when my teams do this, we shock on average. If it's a shockable rhythm, they'll shock twice before critical care outreach or rapid response arrives.
Dr.
amazing.
Roboto.
Duty.
And
It's
So-
your duty.
So we're getting close to wrapping it up, and I'll wrap it up with the ultimate rescuer 1, 2, and 3, right? Because we know that there's a lot of discussion around the country. Who's going to do what? Who's on first? Who are we waiting for? Who's in charge of this whole 9 yards? And that's why we created code rules. Tons of research and evidence-based practice around code rules. Do code rules work? Yes, they do. They work for many. They work for many in many ways. I mean, I think one of the predominant things that stand out to me from my reading of the research is that it really cuts down on that crazy traffic. Right? There's lots of traffic, lots of noise. No one can hear. That seems to be one of the big things. But I always kind of wanted to call bull Scuddy on that, because if you, again, we mentioned this earlier. If you ain't around and your badge is needed, then what? You're gonna wait. So when I'm asked, who is rescuer 1, 2, and 3? Because we have code rules, as you know, Susan, in our asset. That's wonderful. I love your code rules. Code prep comes before your code rules. Code prep is before you get there. So who's rescuer 1, 2, and 3? Everybody. Everybody that has basic life support is rescuer 1, 2, and 3. Rescuer 1, you find the patient, you're up. You call for help. How do you call for help? You holla. begin your jam up compressions, not just any kind of compressions, jam up, save the brains kind of compressions, right? Respirator 2, you're the closest to that person. Your first job is eyes on the prize. With respirator 1, you are the CPR coach. They're going too fast, they're going too slow, they're doing it over the rail, they got pillows and junk in the way. Clear the room. Respirator 3 is the closest one to that crash cart. You grab it, you bring it to the room. You coordinate with respirator 2 to roll that patient, place your pads, backboard, compressions get better, brains get saved, dunsies. Now, when a hospital staff show up with their badges on, if the role they have is not being done when they get there, well, then do it. Everybody's happy. We've done our BLS for the first 2 to 6 minutes. It might be 9 minutes, it might be 12 minutes until they arrive. That's the whole story I have for respirator 1, 2, and 3. So any thoughts on code roles, or have you experienced code roles, and or, I mean, are you down with the whole, if you find the person, you're up, let's do this?
Legal pitfalls of cold rolls.
No, I think that you have to, because it gets too disorganized, and people have to be comfortable with communicating to say, you know, and just be taught that, like, these are in place for a reason. It's the same with like active duty, right? I mean, people have roles for a reason. People die when people don't have roles. You need to have clear and concise roles. So I'm all about it. And the quicker that you're doing that, and someone, just like you said, let's get the crash cart in here. Let's get the defib pads on the patient. Let's start moving. I see that even in, you know, it's when, honestly, I've been to like the units where they're not seen as many codes, like the med surg floor or labor and delivery, where there's just a lot of disorganization because they're not used to. Like, you're walking in the room and they're like, okay, go. And I'm like, wait, what? Nothing's on the patient, nothing's. I'm like, can you at least go get the crash cart? You know what I mean? As I'm going over to do compressions. So I think that everything you're saying is spot on. If we don't give people the tools, and they want to learn, nurses want to, everyone is sweating. Like, oh my God, what am I going to do if there's a code? Like, okay, am I going to be comfortable with that? Everyone sweats every 2 years. Like, oh gosh, we have to take that test. And, you know, it's like crazy. You know, when, just like you said, be comfortable using the analyze button. And like you, when I was teaching LPNs and we went into the rehab facility, that's the first thing that I did. They were like, are you going to touch the defib? I said, I am. And I'm going to teach you how to touch it. I was like, don't be scared of this. Look at this, it has analyze. You know, you're going to know how to do this. It's going to be fine. You will going to pull this into the room. And I just taught them how to, like, even touch the equipment. And if you're not comfortable, like we led with, part of your job as a professional nurse is to say, I don't know how to do something, and to own it, to say, I need some more education, or I don't get this, or I don't understand this. Now, there is a difference between not knowing what you don't know and then not asking for what you need, which as a professional, I do feel like that is part of your responsibility. Like, okay, you're up orientation in a busy ICU after 12 weeks, bye. Well, no, you need to come to the table and say, wait, okay, so I've never seen XYZ, you know, so I need to make sure that I'm getting my orientation. And part of that is I need to make sure that I understand rhythms and I understand the crash cart and what that means and what's like a rhythm that you think I would be shocking, right? And be comfortable with that. Like, show me how to touch the biggest thing that I find that nurses have a problem with is pacing. You start talking about pacing and they are,
Cross-learn.
You know what?
Again?
I think if we added the word porn after all of this instead of training, like pacing porn, code blue porn, you know, ACLS porn, in the training things, like, oh, I think everybody would be like experts. I think that would solve everything. Just call it all code blue porn.
I'm willing to try anything, you know, the visual on that works for me.
I mean, everybody would get into that. You guys going into code blue porn today? Oh my gosh, I haven't done it since like for 2 years, but I can't wait to go again. Ever since they changed the name of that, like, I can't wait to go.
But I do think, Maggie, that what you're saying is also really important, that whole piece about it is your responsibility to ask for what you need, because, you know, in nursing, so often we don't, because we're afraid that somebody's going to humiliate us, make us look dumb, you know, any of those reasons, or you're just a little nurse and the doctor is, you know, this god on a pedestal. And I think it really like hurts our profession that we aren't, that we don't feel empowered to stand up and say, I'm afraid to do a code because I haven't done one in 10 years at even a mock code. And B, we need more training and, and just say what you need. I think we would.
Yeah, no, that's got me crazy now. I got this whole other thought, Maggie, for you, because I'm wondering, okay, so I wonder what the liability is on the hospital when nurses, remember I started at the very beginning by saying Code Blue practice is the #1 most requested educational intervention by nurses. So now where does that fall if they keep requesting it and the hospital doesn't provide it? I mean, that's what they need. They say what they need. I did a survey just recently and it was like 100+ leaders came back with a response. The question is basically, do you think we need code drills in your area? And 85% came back, 85%, yes, ASAP. And then, the system doesn't respond.
Yeah.
So
whose responsibility? Am I supposed to go out and get my own damn BLS over and over again? Or is the hospital, liable for not providing training, adequate training?
You guys already know all that answer, right? I mean, the Hospital Association lobby against us. So this is all rhetorical, but I'm sure I'll entertain you.
Entertain me.
I mean, it is not unless you tell. So you would be a great expert. So for that nurse that say she got caught up in one of these civil criminal administrative cases, who was saying I wasn't trained, and you're willing to write those words down to say what she's saying is valid. But if you're not willing to do that, they don't even know to seek you out or even know that they have this deficiency, which as an expert, I may not know that. This expert Z may not know that. But these hospital associations, again, I have many, my problems, because again, just as you come along in nursing, is that the hospitals lobby against us. And why aren't they listening to nurses? That's just that's evidence right there of that statistic of these nurses begging for help, and they keep ignoring them. It's just another example. It's another slap in the face.
It's a non-issue. Every nurse needs to have the integrity to want to save a patient that goes into distress. Any nurse that's like, well, I wasn't trained. Well, you probably shouldn't be a nurse. If that's your, if you don't want to have the basic capability of starting compressions and saving somebody's life, and you're going to pass the buck onto the hospital that didn't train you. How do you want to feel that way? Like when you go into work, do you want to feel that way? Like, I think, I don't know, maybe it's me, and I don't think maybe it's not every nurse, but to me, it's like, you got a booger on your face, you can't like do basic compressions and do you want that on your soul? Then what Susan asked is a non-issue. Is it who's liable for the lack of training? Well, even if the hospital is liable, do you want that for yourself? Do you want to blame someone else because you didn't save a patient that you could have?
And so, in the case that I referenced, the hospital case, it just showed a more extensive negligence on the hospital and gave the family more money. Yeah. It just showed systemic incompetencies. It just was a poor reflection on the hospital. Why they even went to trial, I don't know. But
Karen's point is so valid, because if the hospital's not going to train us adequately on BLS, again, to own our profession, it's on us, Yeah. And you don't want to walk home or go home from a shift thinking that you didn't know what you were doing. No nurse wants to. We've already talked to several who are terrified to do codes because they're going to go home with their tail between their legs. So owning our profession and becoming empowered and sovereign from the system that's shitty is go and get your training and know what the heck you're doing.
Yeah, and it's not the nurse's fault, this learned helplessness thing, because they're so used to being given everything. So if you don't feel like that yet, that's okay. That's why we're telling you. It's basic golden rule stuff. Would you want yourself or your family member to be taken care of by a nurse who didn't know basic life support or was too afraid to engage in it because they hadn't had the training? If the answer is no, then you should, it's a golden rule. Be that for them what you want for yourself. That's it.
Oh, I agree, but I think that there are some nurses that are really afraid or they're afraid they're going to do it wrong. And I can just tell you my own experience as doing, the first time I did CPR on a 4-year-old and they didn't make it, right? I was the primary nurse for that ER. Mm-hmm. And I think that people take away with them, like, did I do it right? Did I push the right drugs? So there's that as well. Some nurses, and then my mom died unexpectedly at 55, and my dad initiated CPR. You know, one of the first things that he was like telling me was like, how do I know I did it right? And I was like, stop.
Yeah.
I'm not do that.
Yeah, and I'm not saying that.
I think that some nurses, again, if you're going into ICU or the ER, stop. If you can't do chest compressions, probably where you shouldn't be going. Like maybe it's the clinic, or you're doing something that you can do that kind of, you know, a hospice where that's probably less likely for you to do CPR. So I do agree with that, but I do think that there is a piece of nurses, especially if once you've done it, they have like a hesitancy to want to respond, I think. And that's just my opinion.
Yeah, I honestly, sorry, Andra, you know, to wrap it up, and Karen always comes around to that point, and I'm with you on it. I know me personally, that gut-wrenching fear, oh, hell no. I wasn't going to have that more. I did my first patient, my very first day was cardiac arrest, but that gut-wrenching gut fear, nope, not for me. So I went out and found it. I had to get more. And I teach this when I teach, you know, in my advanced life support classes. I'm like, listen, that one chapter we had on, you know, normal sinus rhythm in adult 1, it ain't enough. If you have a curiosity, you have to go get more. Where we work and how we perform in our role is our calling card. So yes, but I also find that's the critical care brain that says, I'm not saying it, but in general, we seek and go towards things that we lean into that way, where the burger tends to be a little bit more tasking thought process, and they're waiting for the permission. They're waiting. It's just who they are. And I felt like we kind of, in the critical care, in the buns, we have failed them by allowing them to be kind of more robotic and more tasking. And then they feel put upon, and we look at them like, what the hell? Why didn't you go do this on your own? But it's just a different type of mindset. And so I feel like I am the permission for the hamburger. I'm the permission. And every other hamburger bun in the country better damn sure listen up. Because if you are a jerk and you're a bag of chips, give it up.
That's the empowering thing, right? That's the empowering thing, is for all those nurses in between. Like if they can listen to this podcast and say, okay, the hospital really needs to train me and educate me. I'm not getting that. I'm going to go and get that and ask them and say it. But if they don't provide it, then I am going to find it myself. And when that response team comes in and I've already got this code, you know, started, I'm going to walk away feeling so empowered that I took care of my patient the way I knew I could. You know, yeah, I was terrified. Yeah, I mean, I'll be the first one to admit, like our other OR nurse, it was terrifying to be in a code in the operating room I was in, because we never got training. But I could just imagine in a med surg floor, OR, whatever, that nurse who said, it's my duty. And I, you know, I'm pissed that I'm not getting it. I'm pissed that I feel afraid. I'm going to go get it. And then that code team's going to come in and we're already going to have this party started.
Yeah. And when they walk in the room, the nurse is going to say, I've got this. Go ahead and give report.
Right.
My teams, by the time they do what they're doing, not only is there time for a pass off, a handoff, right? Like I always say that the red carpet has been rolled out for critical care teams to arrive. Oh, they arrive. Compressions are happening. The scene's under control. There's time for a handoff. And we say, we got this. They don't come in there and say, get out of the way. Oh my God, get out of the way. No, back up, Jack. We got this.
So cool. That's so empowering.
Yeah.
It is. Which is why we're here. Maggie, you're so amazing for joining us. Thank you so much.
Thank you.
And thank you for what you're doing. Thank you. Keep teaching us. Keep teaching us. I do follow you and I'm like, oh my gosh, I don't know any of this stuff. Thank you for your contribution, really.
I appreciate it.
Maggie all the time on TikTok.
Well, I'm only animated and ridiculous because I don't want to. It's the one percenters, right? It's the ones calling me because they're not working. It's the ones that are sleeping in their cars. It's the ones that are standing in front of a board and they've done nothing wrong, or they just got their ankle bracelet off because they accepted an unsafe assignment, an ankle bracelet. So those are the ones. So when I'm animated, it's because it's the one percenters. So I'd rather teach you what not to do than to help you and your legal team defend your conduct.
I think, Maggie, what you do is super empowering for nurses. Like, it just gives nurses this new view about about their profession and what's their duty and what's not. And I like it. You're just super
And,
empowering.
and you deliver it with such common sense and irreverence and humor. And you don't even like, it's like just natural, just your natural way of being like, come on. Do you really want me to take this assignment and break the nurse practice? Like, do you really, come on, I'm here for you. Just, you sign off on this that you're giving me.
We all have
I'm here for you.
choices.
Choices.
Thank you, Maggie.
Choices.
I love it. Thank you so much, Maggie. You're such a valuable
Thank you. Thank you.
contribution.
Will you turn off the recording for a sec?
Okay, I'll edit that out. Okay, bye.
Thank you.
That
Thank
was
you.
very
Bye.
professional of me.